Okay, thanks.
Okay. So decrease in vision in the left eye for the past 8 weeks. He did have a prior retinal detachment repair in that left eye in the 1990s, but says that the two eyes are pretty similar in acuity until these past 8 weeks. This is his past medical history: BPH, congestive heart failure, hypertension, hyperlipidemia. Some surgical history there is pseudophakic. I mean, you can see his medications as well. Just a note, he is on Ocuvite.
Just a really quick, has anybody, I just started encountering people worried about zinc and prostate cancer. I didn't know, it's apparently, it goes back to 2010, that there's a health study that showed that with aggressive prostate cancer, it's possible that taking a lot of zinc is a bad, right? But a lot was over 100 milligrams.
Bad
So
prostate cancer,
if you have aggressive prostate cancer, high dose zinc might be contraindicated. So I've seen 2 patients recently who were told not to take the zinc, but it turns out zinc might actually be protective. And again, it's just a vitamin. People don't study vitamins. So for the most part, zinc is fine for people. If someone's got metastatic prostate cancer, they maybe shouldn't be on zinc. But other than that, if it comes up with any of your patients. Well, for that, it was over 100. The eye vitamins have 60 to 80, which is still a fair chunk, but I had not even heard,
It's supposed to be helpful for your immune system.
it's supposed to be helpful for a bunch of stuff. So I had not encountered it, and all of a sudden I had a bunch of people, so I started digging into
Does that
it.
have to do with your chemotherapy?
There was a study, I think it was the Men's Health study. It was a pretty big study. It was like 36,000 people. And they suggested the zinc kicked out of it, but that was only people with, not with just like, not with BPH and not with localized, it was people with aggressive. If it comes up. So go ahead, you got one case.
The vision in the right eye, 20/25, and the left eye is now 2200. Pressures are normal. Was there patients?
so fundus photo of the right eye, media is clear, nerve looks fine, vessels are fine. Maybe some soft drusen in the macula. Otherwise, pretty normal.
This is the next one.
So fundus photo of the left eye, media looks clear, nerve looks good, vessels are good. It looks like there's a large area of probably subretinal heme, filling the entire macula.
This is just
A wider view, buckle effect of the left eye.
yeah, just noting that. These are both your OCTs for the unaffected eye.
Okay, you guys might have talked a little louder. Oh, the speaker's close to me.
So top left is an OCT of the right eye, bottom right, maybe a vertical cut
Right.
of the same eye, demonstrating lots of extrusion.
And those one count as a double layer sign because the internal reflectivity is the same.
Mhm.
It's not variable, but it was variable, you can worry about it, make it conform like that.
This is an abnormal OCT. See a large dome-shaped, fluid accumulation below Brooks with maybe some fibrovascular proliferation at the top there.
You can use your mouse, everybody can see, you can use your mouse.
Oh,
People
okay.
on the internet can see it, because we're hosting, so.
Gotcha. So large dome-shaped fluid collection beneath Brooks, maybe some fibrovascular proliferations and associated subretinal fluid nearby.
Yeah, really good. So a few others kind of showing this.
Same thing. Also, looks like he's got a lamellar hole developed.
Yes, that's a good pickup, that's very subtle, that's lamellar, what's it,
Yes, a little.
lamellar hole, epimac, yeah, LHEP.
But that's, least of his worries today.
Yes, yeah.
Yeah.
This
Wow.
is,
That's a very large fluid question, millimeter and a half. So IR of the right eye, hypo, what's our hyporeflectivity, probably showing the drusen that we saw earlier.
And those specific ones are reticular drusen.
Yeah, I thought I saw a couple on that OCT.
Yeah, there's a couple, but yeah, there's regular ones, but those are probably, the reticular light up on, yeah, I think those are reticular, I shouldn't say for sure.
Left eye IR showing the similar thing, but also, the hyporeflectivity associated with that fluid collection I'm sorry there.
you can click through if you want. To the FA.
So we see some hyper,
Go back to the early one. Is there one more?
No, these are the,
Oh.
that was the IR, this is the three FAs.
so as we go through, there's this area of hyper, fluorescence. And then later, some staining or pooling, probably in those areas of the subretinal fluid that we saw in the OCT.
And sometimes people call those little things spots.
Or I call them Weppelman ditzels.
Okay.
It's a ditzel. It's a ditzel.
And then this is of the other eye. Relatively normal here.
So ICG of the left eye, probably showing a lot of blocking in the area of the fluid, not seeing the background choroidal filling. Same. We're still seeing those foci of hyperreflectivity or fluorescence.
Is this the right eye?
Yeah, so ICG of the right eye, some hypofluorescence in that area, in the macula. Would that be just some blocking from the overlying,
Sometimes
liquid
it's out of the
fuscin
macula.
deposition?
No, sometimes on ICG, it's just a little dark. It's flow patterns probably. But you'll see that sort of patchy early on. Excuse me.
So same thing, just later.
I want to go back to the FA actually. I had a question. So between the hotspots, when you call this, I was confused if this would be like leakage or pooling of it, because it looks blurred, but then I'm like, it looks like it's filling
Yeah.
in, but not all the way.
Right, yeah, so leakage is when the borders smudge. Pooling is when it fills within a defined space. So you would expect over time, excuse me, the thing would fill. But it's mostly leakage.
Actually, all the pictures, just to sum up, we have in the right eye, some dry AMD with those soft confluent drusen, and then in the left eye, have that kind of grayish green discoloration in the central macula with what looks like subretinal and some intraretinal hemorrhage, and a noted scleral buckle repair in that eye. In the OCTs, you have some sub-RPE nodular elevations in the right eye, in left eye, there's a large pigment epithelial detachment with some hyperreflective material in subretinal and sub-RPE spaces. The FA showed those hyperfluorescent spots kind of in the superior macula with kind of that large area of leakage versus pooling that doesn't fill completely. And then kind of same things with the IR and the ICG, you have this central hypofluorescence with those hyperfluorescent spots superiorly. So I think I did a animation for the differential, okay.
So top of the differential would be a conversion from stable dry AMD to wet AMD.
Okay, good.
Trauma. Just CME from the prior surgeries, but it's much lower on the differential and ruled out the.
So if you wanted to get more specific for wet AMD, there's a couple different subtypes,
Well, I think he's got a choroidal neovascular membrane.
right?
So there's
Developing.
different classes of that too, so you can go through different causes of CMV other than AMD.
Oh, yeah, for the differential. If you want to make your differential better.
You could have other inflammatory conditions,
Yeah,
PIC.
yeah,
Yeah, there,
it's the,
myopia, trauma with rupture.
right,
So that's kind of what I had on here too, wet AMD being higher on differential, but you can also consider like, is this a tumor or other reasons for CNV like histoplasmosis, ruptures, pathologic myopia? Any other things there? So this case was wet AMD with RAP, which is retinal angiomatous proliferation. And so that's a distinct form of wet AMD. And it's when the neovascularization starts in the retina and then actually progresses posteriorly into the subretinal space and the choroid.
Is that what that spot was?
that's when the hot spot. So when you see a hot spot, you think of retinal angiomatous proliferation.
And so these are actually some pictures, post-treatment. I have, let's see, so the second picture, the patient was after Avastin, or the first was after Avastin, and then the bottom two, I believe, were after, Lucentis injections. And then on the right-hand side, the third and the fourth was after Eylea and then the Bispo.
So it's kind of, so if you look at the binding affinity, because what was I worried, what I was worried about with that case? Well, I didn't go right to Vabysmo. If I went right to Vabysmo, there's a 30%, really high chance of something bad happening.
Red.
Yeah, red. So, because that was over, do you have it in there, the height where the cut was it?
Yeah,
Okay.
14.
Yeah, just, well, you have the height though, where I got rips.
Oh, 600?
Yeah, I think it's,
Yeah.
okay, 600, because I don't know. So it's about, so when they're over 600, the risk of an RP rip is pretty high when you start anti-VEGF therapy. And it's a crummy thing, because you have people who are 20, 40, 20, 30, and they drop to 5,200 because they rip in the hemorrhage after the first treatment. And it's pretty common. So what I do with these is Avastin, although the last one I did this to it, I still tore on Avastin. Oh no, you know what I did? I did a quarter dose of Vabysmo, which I probably shouldn't have done. I've even done these with
They can
steroids.
tear on their own.
Yeah, they can tear on their own. So it's hard to say
It's
when it's
not,
our fault.
yeah.
It's not always our fault.
Mhm.
But anyway, but that was the idea. So Avastin's supposed to be 1/70th as strong as, 1/70th as strong as Lucentis, and 1/40th as strong as Eylea. And I don't know where it is for Vabysmo for binding affinities. So people look at binding affinities, and Avastin's much weaker than Lucentis, which is a fair amount weaker than Eylea, which is a fair amount weaker than Vabysmo.
So the rips are more associated with the Vabysmo than
With the
others?
strong, no one's doing that. But what happens is CMV contracts
Mhm.
and then it rips. So I was trying to get it to slowly
Mhm.
get better.
Okay.
I don't think anybody's ever published on this. I don't even have enough.
So you start with Lucentis and then Eylea.
I did Avastin. Yeah, Avastin.
Avastin,
Lucentis.
then Lucentis, then Eylea.
Lucentis.
The you'll escalate.
Yeah,
So you're just
well, no,
trying to
actually, it was
calculate.
pretty flat after the Lucentis.
Yeah.
I think the first one was one they've asked, and the second two were Lucentises, the third, second two, then these two on the right were Ivy, and then finally the last. So,
Yeah, sometimes you just, if you control the actual leakage, it can still have that persistent PED. I've had patients with that, and I always just kind of keep them on the same medicine, because I don't necessarily want to flatten the PED always, because I always worry about a tear.
right,
So I've had patients like with 20/20, 24 vision, 20/40 vision with that elevation. As long as they're okay and stable, I kind of keep them, and not necessarily try to flatten the PED. Just really maintain.
So just some points about AMD. AMD is an acquired degeneration of the retina, can cause significant central visual impairment, and it's classified in two classes. There's dry AMD and wet AMD. Dry AMD is the majority of cases, and it's the non-neovascular kind that's defined by the presence of drusen and then also RPE changes. Versus wet AMD comprises about 10 to 15% of cases and is the neovascular type, and that's defined by choroidal neovascularization. And kind of just in the changes in dry AMD can form that pro-angiogenic environment that can lead to the neovascularization and development of wet AMD. So within wet AMD, there's kind of three classifications, and it's based on the location of the neovascularization where it starts. So type 1 choroidal neovascular membranes is when the vessels originally in the choriocapillaris, and then they grow up through Bruch's membrane and then can lead to PEDs. Type 2 is when the vessels originate subretinally. And I saw noted that can classically be seen as like a lacy green lesion. And then type 3 CNV is also the same thing as the RAP, where the vessels actually originally in the deep capillary plexus of the retina and then grow downwards towards the RPE and into the choroid. So within RAP, it's equivocal to type 3 CNV, and these are kind of the stages that you see. So you start with this intraretinal neovascularization, and then it starts to grow down into the subretinal space, and you can start to get like a serous PED, but then once it extends into the choriocapillaris, you get that fibrovascular PED.
and I don't know why these generate those giant PEDs, for some reason or other, the type 1s, the PEDs are kind of low, like the double layers of type 1. The type 2, you tend to not get that much of PED, mostly kind of subretinal. And then these type 3s, you get these monster, and also polypoid cortical, you get these monster PEDs that are just kind of scary.
And then I saw that type 3 or RAP is about 10% of cases.
Yeah, that's probably good.
And then these are just kind of like an overview of treatment for AMD from the BCSC. Previously, I think we kind of talked about this, there's laser photocoagulation that's not really done anymore from poor outcomes and high recurrence rates. There's also photodynamic therapy, is where you apply like a photosensitizing drug, and then application of light specific wavelength results in a reaction that can induce CNV thrombosis. This was shown to like slow progression, but doesn't really prevent significant vision loss, so it's not practiced anymore. The mainstay of treatment is your anti-angiogenesis drugs or anti-VEGFs. Mostly, let me see here. There's quite a few trials in here, but when comparing, I forget the brand names, I'm sorry. I wrote them down.
Yeah, it's good not to, Brandon.
Okay, but ranibizumab was shown to have visual acuity improvement with monthly injections, but was not shown to be as effective when the injections were more spread out to quarterly. And then aflibercept had a little bit better visual acuity gain, 10.9 versus 8.1 letters, when compared to ranibizumab and when they were doing monthly doses. And then Avastin or bevacizumab also showed, non-inferiority when compared with ranibizumab. I also noted here the kind of the complications when you have such a high fibroblascular PED, the height greater of 600 microns, you have a much greater risk for RPE tear, following injections. I saw that that's due to the contraction of the CMV from the drug action. And I saw that sometimes you can also do surgery if there's like a intravitreal or subretinal TPA, you can sometimes do if there's like a thick submacular hemorrhage, but I don't know if
We go all
really
over the place on that. Currently, it's in favor. I think the Eichenbaum had a good case and now everybody likes it. I go back and forth on the subretinal displacement. We've done everything for macular degeneration, like pavement could tell you over the years, like anything you can think of, we've done. The shots are so much better than everything else that they're almost always what you do. The submacular hemorrhage, you can displace it. So what you do is you put a bleb, you put a bleb of, you go in surgically, you inject a bleb of fluid and tissue plasminogen activator over the hemorrhage. So you can sometimes put a little air under there. Again, some people do, some people don't, under the retina, which is kind of cool. And then you have the person sit up. And the idea is the TPA dissolves the clot and then the fluid lets it drop down. So it's not in the center of the macula. And some people show these staggering results. I don't think I've ever had a case do that well. You know, I've probably done 5 of them. I don't do that. The other thing you do is pneumatic displacement in the office. This is all for submacular hemorrhage. So for submacular hemorrhage, you can put a bubble in the office, have them look down and do this like head bob thing, which you can have, that's pretty non-invasive. So when you put the bubble in the eye, they can see the bubble and they can see their blind spot. So you can have them kind of bring them together, almost like they're playing a little game. And then when they bring them together, the bubble, then you kind of have them look up a little above and sit up. And again, some people show great cases. When I was in fellowship with Maria Baracall 31 years ago, she pulled all the hemorrhages. She did a very good paper on subretinal hemorrhage out of Miami, and she just went through we had these separate photo files on all the patients. So she didn't look at charts, she just looked at photos. So all causes of submacular hemorrhage. And what she found, which I think is completely true still, is basically submacular hemorrhages from macular degeneration just don't do that well because they have macular degeneration. Submacular hemorrhages from non-macular degeneration do pretty well because they don't have macular degeneration. And what you do, I don't think makes all that much difference. Are you operating them or are you?
No, I've done in-office schematics. And generally, they don't do much. I've had one
Right.
patient that displaced a lot and
Right.
did great.
That's why everybody gets all excited. They'll
You
see how like
know,
one patient does like remarkably well.
TPA, I just found I have a great access to it.
Right. And then the other thing is the timing, so, and the size. So basically, you don't wanna, if it's there for more than, I don't know, a couple of days or a week, you don't wanna bother, because it's too, you know.
And if
the
it's
damage
sub
probably not-
RPE, you're not.
If sub RP is not gonna help, and if it's too small, it's not worth the risk, and if it's too big, it's probably not gonna help. So you're looking for this Goldilocks lesion, which is just about like maybe just inside the arcades, subretinal, fairly fresh.
Most of the time, we just inject them with anti-VEGF and just let it resolve on its own.
And then speaking of timing, if you do inject and you do get a rib, when would you expect to see the rib?
Usually the first shot. It's almost always the first shot. I have to say, the other thing I've seen, which makes me, frustrates me too, is when Eylea came on the market, 2010, I had some people I converted who tore with the conversion, which was a little aggravating because they were seeing pretty well. And I was like, I'll get rid of that extra fluid. I switched the drug and they tore. And so I think it's definitely something to do with the strength of the drug and the lesion.
That's why sometimes I just tolerate the PED.
Yes, I'm smart. Yeah, there's some evidence that, you know, subretinal fluid, because the other thing is 20 to 40% of macular degeneration patients lose vision from central geographic atrophy. And there's some evidence that people with there's 10% with chronic subretinal fluid, sorry, my voice, that might be protected. So those people with chronic subretinal fluid, actually, as much as you think, oh, those people over 10 years are actually gonna do worse than the dry ones. A lot of them chug along at 2030 or 2040, and they almost never atrophy with the subretinal fluid. It might, and I don't know if what we do makes a difference. So that's not to say you should not treat fluid, but I think it might be something with the lesions. Yeah, there's a lot. That's why for all the presentations, this is the important one, because you're going 50% of our practice is macular degeneration. You're not going to see as much as it's interesting. Choroidal melanocytosis is probably not going to crush your head. And melanomas are pretty rare, but and artery occlusions are important, but wet macular degeneration is like a giant part of ophthalmology.
And I also thought this is interesting. So in the comparison of AMD treatment trials, the eyes with RAP actually seem to have a better response. They were less likely to have fluid leakage and scarring when compared with other eyes without RAP after injections of ranibizumab and bevacizumab. At 1 year, these results were seen, but however, these differences didn't persist at year 2. So they seem to respond, I think, a little bit better initially, but then longer out.
And I have to say, this was a big deal because RAP lesions are so bad that I think they were excluded from the early trials because the PD3 trials showed that the RAP patients didn't do very well. So it used to be RAP was kind of a little more of a death sentence, but now it seems like they actually do everything. The shots seem to take care of everything. That's why when people complain about the shots, I think I'm one of the few people left that have perspective of what life was like before the shots.
Mhm.
So when someone's like, oh, I have to come in every 2 months or 3 months, or like, you know, and a lot of those people, because it is somewhat genetic, have relatives who've gone blind. So a lot of times they say, yeah, I know my mom didn't have the treatment, she lost her vision. So at least I know.
If you catch these RAP lesions early, they respond so well, and so it's really very nice because you know what could happen if you didn't have that treatment. So I tend to keep treating those lesions.
And one other RAP thing, it's because we talk about cases a lot, it's not, where I see these early, like, is we always the fellow eye. So you'll be treating one eye with macular degeneration, the fellow eye starts to look a little funny because you're scanning when they come in. And sometimes it'll be just a little edema. And you're thinking, you know, it could be a little edema, it could be not, you know, because sometimes dry gets a little edema. Or it could be that they have cataract surgery or just they're a little inflammatory and they just have a little bit of macadamia, you're like, but that might be a RAP lesion starting. So then we kind of watch that a little closely. And as soon as it starts to die, then you treat it and they do well. It's true.
And I don't know if you guys have seen this too, but this treatment trial also noted that eyes with RAP were more likely to have geographic atrophy.
Oh, later.
So,
No, I didn't see that, but that makes sense.
That's all I have.